Hello, everyone. Welcome back and welcome to part 3. We're going to start off part 3 going over that case study that you guys have been working on here. All right, so what are the answers to your case study number 2? Well, different bacteria can cause rashes, not just one bacteria. There's many different ones. Example, the rickettsia can cause spotted fever. Salmonella can even cause a rash. Borrelia burgdorferi causes a rash as well. Staphylococcus aureus and toxic shock syndrome can cause a rash. Streptococcus pyogenes can cause a scarlet fever rash, and Treponema pallidum can also cause a rash. So what serology can be used to diagnose all of those different types of infections? Well, VDRL is a test for syphilis in the spinal fluid. A rapid plasma reaction, which we talked about, is kind of a screening test for syphilis in the serum. And then we have the confirmatory test, FTA-ABS, for that one. We have some agglutination tests for Lyme's disease, which was the Borrelia burgdorferi, strep pyogenes, and spotted fever as well, as agglutination. Staph aureus is usually it's gram-positive, coagulase positive, which you know from microbiology. So what is the disease? How did the 6 residents of Ford County get this disease? Well, syphilis. Patient number 5 apparently brought the disease to Ford County and gave it to patient 3 during sexual intercourse. They could have given it to others as well. Who knows? What are the consequences of not treating this infection? Well, secondary syphilis could lead to tertiary syphilis, which usually can cause the brain issues and the central nervous system issues. And a fetus could also contract the congenital syphilis if somebody were to become pregnant through this behavior. So I hope you had some fun with that one. It was kind of interesting. All right, we're going to run through many more diseases here in part 3. We're also going through and we're going to look at some of the autoimmune diseases, the immunoproliferative diseases, rheumatoid arthritis, and then we're going to finish off with some organ transplantation, bone marrow transplantation, and tumors. All right, let's move on to cytomegalovirus. Well, CMV is a member of the herpes family. It's a large envelope DNA virus that undergoes replication nucleus of a cell, as most viruses do. After they replicate inside the cell, we have a sort of a viral burst. The cell bursts open, more viruses are released to infect more cells. CMV likes to spread itself to the lymphoid tissue and circulate through the lymph nodes. The epidemiology of this is orally, respiratory, and it can even be venereal routes as well. One of the common ways that it's transmitted is through blood transfusions. And if any of you have been in the blood bank departments that you did your clinicals at, you may have noticed some of the units are tagged CMV negative. Well, they like to give those units to the immunocompromised patients just to make sure that they cannot be infected with this, because it can cause a lot of problems in those immunosuppressed people. Most people have had some type of CMV. Most of us have maybe even had it, and it causes some cold and flu-like symptoms. Latent infection can occur later in pregnancy or with immunosuppression, and it is a major cause of death in AIDS patients. As you can imagine, AIDS patients already are immunosuppressed, and this would just be another challenge that they would have to overcome. The congenital infection, it is the most common uterine infection. Most newborns do survive, but they may be mentally retarded or suffer some other health problems. A couple different signs and symptoms. An acquired type of syndrome where it's usually asymptomatic. Incubation is 3 to 12 weeks. We've got those cold and flu-like symptoms with the sore throat, fever, swollen glands, chills, etc. Complications of hepatitis. Remember, when you have hepatitis, it doesn't necessarily mean that you have a viral hepatitis caused from hepatitis A, B, C, D, or E, but it could mean just an inflamed liver. Guillain-Barré syndrome and myocarditis can also be some other things that can happen from having CMV. It can be life-threatening to those immunosuppressed patients, which is why we're so concerned about this. There are also congenital issues that causes the neurological symptoms of the mental retardation that we talked about, petechiae all over their body, and we have cytomegalic inclusion disease as well, which is really bad. It alters the immune system. It can alter T lymphocytes and increase the number of CD8 and decrease CD4, just like AIDS does. And the presence of the immediate, early, or the early antigens is associated with an active infection. So the way we diagnose this in the lab, we can examine the blood smear for leukocytosis. They'll have usually mono-like symptoms, but they'll have a negative mono test. They may have hepatitis or liver inflammation, but they would have negative testing for the hepatitis viruses, but have increased liver enzymes and such. We would find low platelets, and we would find an increase of the CMV, IgG, or IgM titers. Our next disease here, or illness, is mono, caused by the Epstein-Barr virus. Now, Epstein-Barr virus not only causes mono, it can also cause Burkitt's lymphoma, which causes these large lymphatic-type tumors. And you can see this poor child on the right-hand side here happens to have it in his face. Sometimes you see it in the neck. In the United States, people usually don't become disfigured like this from Burkitt's lymphoma because we do have health care that's readily available, and usually it wouldn't get this bad. But third world countries and things where they don't have the medical care that we do, sometimes these, poor children end up with large tumors like this before anybody gets to try and help them. It also causes infectious mono. It can cause nasopharyngeal carcinoma and neoplasms of the thymus, parotid gland, and larynx. It is a member of the herpes family. It's a virus that affects B lymphocytes, which become variant. So when you looked at those variant lymphs in hematology, where they said, oh, this looks like a mono patient, they look like they're hugging all the red cells that kind of spread out like a giant amoeba. That is what is very indicative of someone having mono. Usually a 15-year-old would come in the lab and with a fever and malaise and things like that, and you see those virulent lymphs and you go, oh boy, here comes a mono. Sure enough, doctor, odds a mono and it's positive. It's usually transmitted by close contact. Sometimes around here we call it the kissing disease. Just oral pharyngeal secretions and possibly by blood transfusions as well. About 90% of all adults have antibodies to the virus. So you may say, well, I have never had mono. You may have had mono, but it was such a mild case that you didn't realize it. It's usually, which is probably when most of us have had it, the older you get, the worse it gets, kind of like chickenpox. The older you are, the worse the infection is. It causes fatigue, malaise, sore throat, fever, lymphadenopathy, and splenomegaly in 50% of the patients. Again, we'll have the hepatitis and the abnormal liver. And to test for this, the heterophile antibodies, which are stimulated by one antigen and react with an entirely unrelated antigen present on mammal cells. The IgM heterophile antibody appears in the acute phase of mono. So when they're acutely ill, we see the IgM antibody. With this, and this test you may or may not have done in your immunology lab, I know we've done it on my campus, reacts with the horse, ox, and sheep red blood cells and are not absorbed by guinea pig kidney. It does not react with Epstein-Barr virus antigens either. Usually to diagnose this, we run a CBC, we do some serological testing, and a big telltale sign are those atypical lymphocytes. A couple different types of tests have been done in the past. You want to be familiar with these. Hemagglutination, that heterophile antibodies present in the patient's serum were picked up, and they used sheep's red blood cells. But the problem with the Paul Bunnell is that it picked up Horseman heterophile antibodies as well. Came along, and he distinguished between the heterophile antibodies that agglutinate the antigen-bearing RBCs of sheep. Guinea pig kidney absorbs other heterophile antibodies to get them out of the way. So Davidson was a much better test because it didn't have those interfering other heterophile antibodies that we weren't looking for. All right, next one is AIDS. AIDS starts known as HIV, human immunodeficiency virus. Some of the characteristics of HIV is from the Retroviridae family. It converts viral RNA into DNA and reverses the normal process of transcription. So we call it a retrovirus. Okay, so it does things kind of backwards. We find that the HIV glycoprotein 120 binds to T cell CD4. Okay, so our T helper cells. We need helper cells, right? Because they help us fight off infection. The two different types are HIV1 and HIV2. So there's two different types out there. Well, just to back up a little bit here, once it attaches itself to that T cell, it injects its genetic cell. It uses the genetic material from the cell to replicate itself. So once you have all this replication, it goes through this life cycle, as you see in this picture, and we've got extra viruses being created from that. There's a viral burst. It releases HIV to go and infect more T cells. It's the fourth leading cause of death worldwide. It's usually held in the leukocytes and carried in fluids, body fluids. And in most cases, HIV lasts 10 years until it turns to AIDS. The ratio of T cells, T helper, T help, I'll type this on here, to T suppressor is, not agree with me here, 2-to-1, okay? What happens is once you start to attack those T helpers, that ratio starts to flip-flop. And when you start having more suppressors than you do helpers, that's when they start to turn into the AIDS patients, the acquired immunodeficiency syndrome. That's when they fall into that new category. Things that happen when that happens is they end up getting sick from things that usually don't get healthy people sick. Things like, and then we call those opportunistic infections. Pneumocystis carinii, those tend to cause big problems with AIDS, CMV, which we just talked about in the last slide. Certain forms of TB like to harbor in AIDS patients. Toxoplasmosis, herpes, Legionella, and histoplasma, those really like to cause issues with the AIDS patient. We do find Kaposi sarcoma type cancerous like looking lesions all over their skin. I always picture what was his name, Tom Hanks in the movie Philadelphia. He played a HIV AIDS patient, and he had that Kaposi sarcoma all over him. So over time, as I said, there's a sharp decrease in the T cells, and it causes the flip-flop of that ratio. So how do we treat this guy? Well, unfortunately, there's no cure, but we can try and slow it down by using HA heart therapy. That's highly active antiretroviral therapy. It helps prevent those opportunistic infections and slow down the viral replication of this. The other one is the NRTI, the nucleoside analog reverse transcription. You certainly don't have to memorize those drugs, but know that there is antiretroviral therapy that they do give those patients. Immunological manifestation, again, depletion of T cells, and detection of the core antigen with viral burst. When there is a viral burst, we'll be able to detect that. So how do we test for this? Well, we look for the HIV P24 antigen, and we confirm it with the Western blot. The Western blot does check for that P24, also glycoprotein 41, and a PG120-160. Those tests can be done to confirm that they do it. While many of the labs that you guys may end up working in do some testing for HIV, do some screening, they would never confirm with that patient that they have HIV till they send it out to a reference lab for that Western blot. Okay, our next one is hepatitis. We're going to take a quick run through all of the different types of hepatitis. That's how you even say it. The different forms of hepatitis include acute, which means that you are acutely ill. Fulminant acute, which is actual hepatic failure, taking subclinical hepatitis without jaundice, means there's antibodies in the serum, but you don't feel ill. Having chronic hepatitis, which is in inflammation and necrosis for 6 months. And this we find in 10% of your hepatitis B patients. The viral DNA is in the liver cells of the patient and can lead to major issues with that. All right, first hepatitis, hepatitis A. This is a small, non-enveloped RNA virus with a nucleocapsid. It's transmitted by the fecal and contaminated water supply. It increases your liver enzymes, causes bilirubin or high bilirubin and jaundice. There's this happened in Green Bay. It's McDonald's. Oh, so if you're from Green Bay, you know what I'm talking about. If you're not, you have no clue. The airport, and it was one that when I was getting a master's degree, I went there all the time. And they had a person who got hepatitis A, and she already had other issues. I want to say she already had hepatitis B. So she came to work, and they had a hepatitis A scare at this McDonald's. So there was actually people that came to eat there that came down with hepatitis A as well. Turns out that she died and didn't make it. Her liver just couldn't handle the two types of hepatitis. It was a big thing in Green Bay that everyone, that, oh my gosh, these people are dying. They went to this McDonald's, and this poor McDonald's, I don't think anybody went there for, I don't know, half a year. And all I could think to myself was, this place has been shut down for 2 weeks, and they have bleached and cleaned every single corner of this McDonald's So I figure I'm definitely going there because it's probably the cleanest mix in the United States at this point. But that's me. So anyways, that's hepatitis A. That's your foodborne. Hepatitis B is the only DNA hepatitis that there is. So you're sure, which one's DNA, which one's RNA? Hepatitis B is the only. It's a complex double-shelled DNA called it has a Dane particle. It's transmitted through blood and body fluids, but not stool. And there's certain tests that we do. Well, if you do a hepatitis B surface antigen, that is the initial marker during incubation. So this means you're sick, and you can infect others because you have the actual antigen in your blood. There's also the hepatitis B E antigen. This means you have a very high degree of infectivity. There's lots and lots of replication going on. This is where they want you to really stay away from other people. There's also antibodies we can do. We can do the hepatitis B core antibody. It can be written either way. It can also be written as anti-hepatitis B core. This means that you've had a recent hepatitis B, and this happens between when the hepatitis B surface antigen disappears and the hepatitis B surface antibody appears. So the core kind of means you're starting to improve. Then we get the hepatitis B E antibody, or the hepatitis B surface antibody. Those develop during the convalescent stage and recovery. Now, hepatitis B surface antibody can occur in a couple different ways. If you have the hepatitis B E antibody, that means that you are recovering from a recent infection. And hepatitis B surface antibody can mean the same thing, but it can also mean that you've had the vaccine. Okay, the next one we'll move on to is hepatitis C. From blood or blood products spread by, or can be through IV drug use. Very slow and progressive, often silent. You don't know you have it. You have high liver enzymes. They can treat that with interferon as well. Hepatitis D, the virus. It's only people with hepatitis B can get it and must come in contact with someone who's had the hepatitis B surface antigen and the hepatitis D virus. Hepatitis E is common with fecal-oral route, poor water sanitation, kind of like hepatitis A. Hepatitis G is very close to C. It's very, very, very common. 1% to 2% of blood donors test for it, but it's not something that we hear about very often. All right, let's move on to hypersensitivity reactions. I don't know if you guys have ever seen the movie Pure Luck with this guy right here. His name Martin. It's escaping me right now. But he gets stung by a bee and he's very allergic. And normally he's very, very tiny. Martin Short, that's who it is. Very, very tiny. And he ends up blowing up in this big hypersensitivity type reaction. His would have been more of a type 1 reaction. But what a hypersensitivity reaction is an immediate or delayed, normal but exaggerated or uncontrolled immune response to an antigen that can produce inflammation, cell destruction, or tissue injury. As you can see, major inflammation with this guy. We refer to things as allergens or having an allergy. Another word for allergy is atopy. IgE is usually involved. Remember, he's the big player that releases heparin and histamine from basophils. Hay fever, asthma, food allergies, latex, those are the most common. Other types of antigens can be environmental, can be infectious, or it could be your own. It could be to yourself. All right, so let's go through each of the different types. First one is type 1. This would be your typical anaphylactic reaction involving IgE, which would have the release of histamine and heparin from the basophils and mast cells, etc. So you would have the itchy sneeziness involved. There's not a lot of cell destruction taking place. This would be your typical hay fever, asthma, and food allergies. Type 2 is antibody-dependent, complement-mediated cytotoxic IgE reactions. This is where the transfusion reactions, also hemolytic disease of the newborn and autoimmune hemolytic anemia. So as you can imagine, complement would be involved because we do have the anemia situations and the lysing of the blood cells. Macrophages and polymorphonuclear cells are involved, and we do DATs to test for this one. For type 3, this is our immune complex reactions involving IgG and IgM. We call this the immune complex disease. For example, farmer's lung, systemic lupus. We do an immunoassay to test for the rheumatoid arthritis and some of the other ones as well. Type 4 is a cell-mediated hypersensitivity. These are T-cell dependent. It's delayed. It involves antigen-sensitized T-cells. Complement is not involved. And examples of this would be having like a latex allergy or some type of contact dermatitis. An example would be a TB skin test. Another one I think of is I'm allergic to nickel. I have this necklace, a cheap necklace, and it not only turns my neck green, but it makes it really itchy. All right, next infection we have is rubella. Rubella is also known as the German measles or the 3-day measles. He's an enveloped single-stranded RNA virus of the Togaviridae family. He's transmitted by respiratory secretions. And 13 to 15% of adults usually who get the vaccination can get arthritis as well. It's usually can be acquired or congenital. Acquired usually takes a 10 to 21 day incubation and usually contagious for about 2 weeks. It begins with a fever and then you get the rash. Congenital is where this becomes much more serious. The first trimester, infection can be very devastating to the fetus. If you are pregnant, at least if you go to any hospitals around here, they do a rubella antibody test on all pregnant women. They do this to make sure that you don't develop a type of infection. They want to make sure that the mom's immune to this. The initial immune response following fetal infection with rubella is the production of IgM. So if IgM is present, that means you're actively ill, just like every other disease. If you have the IgM, it usually means you're actively sick. To do hemoglobin inhibition with, in some cases. There's immunoassays and such too. All right, let's go over some lupus here. We have different autoimmune disorders. You can have organ-specific, mid-spectrum disorders, and organ-non-specific disorders. Examples of autoimmune would be something like lupus. Organ-specific would be Hashimoto's thyroiditis. If you remember from chemistry, that is the attacking of the thyroid with autoantibodies. You can have mid-spectrum disorders that include idiopathic thrombocytopenic purpura or multiple sclerosis, and organ non-specific disorders where it's not attacking one specific organ, it just affects many. Factors that influence autoimmunity, well, it begins with an abnormal interaction of T and B lymphocytes. Things that can cause this to happen include increasing age, genetics. I know I've got autoimmunity in my family, so that's probably why I ended up with autoimmune diseases myself. UV radiation can change the way your cells. The thing about your skin, if your skin is exposed to a lot of sunlight, that radiation can change the way those skin cells look and cause your body to actually attack those cells. So that can cause some skin irritation. And radiation, of course, does the same. We can have immunopathic mechanisms where immune complexes are formed. They can be complement and cytotoxic T cells. And we can have an increase in helper or decrease in suppressor that can trigger B cells to produce autoantibodies as well. One of the tests that we do is the ANA, anti-nuclear antigen. This is positive in 99% of lupus patients. But it's not just present in lupus, it's present in other diseases as well, which we'll see here in a minute. We'll start with the most common one, which is systemic lupus erythematosus. We call it lupus for short. You can see this person on the right-hand side here with the characteristic butterfly rash. It almost looks like she just has a rash or something. Some of the different types of lupus is a discoid lupus, which is about 10% of cases. That's caused by the drug away, the condition clears up. Another type is mixed connective tissue, that's about 10%, but the majority of people have a systemic lupus, which is systemic lupus erythematosus, that affects the skin, joints, lungs, kidneys, and the heart. It's idiopathic, we don't know what causes it, but usually a defect in the regulation of the immune system. It just kind of gets out of control and starts attacking things that it shouldn't. The majority of people that get lupus are women aged from puberty to menopause. Pregnant, the symptoms really worsen. And I've had a firsthand experience with this. I had a tech that I was working with at St. Vincent Hospital, and she worked nights with me, and she got married. She wanted to have a baby really bad. Well, the doctor kept telling her it wasn't a good idea and that she would have issues. Well, sure enough, this person decided to get pregnant. Well, this poor girl. I can't tell you how many times she had to go to the doctor while she was pregnant to get these things monitored. She did more 24-hour urines. She did more blood tests and everything that you could possibly imagine, took more medications to try and control this while she was pregnant. Fortunately, she got through it and had a healthy little baby girl. But it was a very, very trying pregnancy, if I remember, because I was pregnant around the same time, and I didn't go through anywhere near what she had to. The things that can cause drugs, we talked about the drug-induced, or lupus, sorry. Drug-induced procainamide and anticonvulsants can cause the discoid lupus. Some of the signs and symptoms, it can be acute or chronic. You have that butterfly rash. In general, you have arthritis, fever, weight loss, which is not feeling well. Lymph nodes can be involved, osteoarthritis, which is inflammation of the abdominal cavity, inflammation, general inflammation of the myocardia as well. They have a rapid heart rate. Some of the immunological manifestations, you can have T cell and B cell function. Circulating immune complexes can cause problems, especially with the kidneys and lungs. Antibodies to nuclear components we'll find. And the ANA would be positive. Also, what would be positive is the Smith antigen. So a Smith anti-Smith is what type of test we would do. They'd have a prolonged pro-time, they'd have thrombocytopenia, lymphocytopenia, and they used to do a lupus cell or LE cell test where the cells would look swollen. It's not something you see too often anymore, but if you come across that on your boards as having a positive LE cell test, that would lead you to lupus. Some of the diagnostics, we have high levels of anti-DNA antibodies, which complement breakdown products of C3, and we have increased IgG and IgM with a low IgA. Here's the patterns that I was referring to with the anti-nuclear antigens. What they do is they take the patient's cells, they look at them, or they take patient's serum and they look for antibodies to different parts of the cell. So these cells are already on the slide. If there's fluorescent present, there's antibodies there. So depending on the pattern that is put on the cell, it can give you an indication what's going on. So if you look under the microscope and you see a homogeneous pattern where your cells are all pretty solid green, we refer to that as a homogeneous pattern, and we see that in rheumatoid arthritis or lupus. So if you did a screening type cell or screening test, ANA, then and it was positive and it was homogeneous, you would go on and do a rheumatoid factor test or rheumatoid arthritis test, and you'd also check for the Smith antibodies. In a peripheral type of pattern, you can see on the left-hand side, just the outside of the cell is green. With this, we find that in active lupus and Sjogren's disease. So again, you would go and do check for the Smith antigens and things, and you'd also do like an SSA, SSB. There's all kinds of additional antibodies you could do to check for Sjogren's. Next one is a speckled. If you see it all speckly, that could mean that it's lupus or it could be Sjogren's. So again, you'd have to go on and do additional testing to see which antibodies are there. The pattern is just the nuclear material is nuclear material is just is the only thing fluorescing. That is present in 50% of patients with scleroderma, and it can be Sjogren's and lupus. So again, if you think they might have scleroderma, they might do all 70 antibodies. Sjogren's, they might do SSA and SSB, and for SLE, they might do anti-DNA or a anti-Smith. The last one here is the anti-centromere antibody. This one looks really cool because you can actually see the centromeres lined up. And that one, we find they are usually having Crest syndrome and scleroderma. What scleroderma is, it's the hardening of the skin. And I had a neighbor, I know you guys think I have a story for everything, but I had a neighbor, our neighbors down the street, their daughter died of this. And I had to draw her blood when she was in the hospital when I was a student. Her skin was like beef jerky. And I apologize if anybody has a family member who's had this, but the skin gets really, really tough. And I remember it being really hard for her to straighten out her, really hard to find a needle. She also had to talk like this because she couldn't move her face at all. So she could barely talk. So essentially the connective tissue and things in her skin were being attacked by these antibodies and causing it to turn almost to stone. And when they say Crest syndrome, refers to calcinosis, having respiratory issues, The EST is escaping me right now, but the CREST syndrome are just the symptoms you have when you have scleroderma. So again, with that, they would do the FCL70 antibody to see if they do in fact have scleroderma. All right, let's move on to some of these immunoproliferative disorders. We have a couple different types. There's monoclonal gammopathies and polyclonal gammopathies that we're going to talk about today. What they do is a serum electrophoresis. And what they do is you have a total protein in your blood, right? So total protein includes all different kinds of proteins. It's not just one protein. So if you have an elevated total protein, the doctor might order an electrophoresis. And what electrophoresis does is divides your proteins into 5 different sections. So you've got your albumin is your first one. That's a big peak. He's the one that's the biggest and in the biggest abundance in your blood. So he's this big peak right here. Okay, that is your albumin. One you have is alpha 1. He's a little tiny peak in here. Then we've got alpha 2. He's a little bit bigger. Oh, my circles aren't working. And then we've got beta. And then then there's gamma. And this top one right here, multiple myeloma, a normal peak would look like this one right here. Okay, you've got a big albumin, kind of a small alpha 1, a little bit bigger alpha 2. We have a little beta in there, and then you've got this big kind of wide lump. That's your gamma. Well, in monoclonal gammopathy, it means you've got one big peak in your gamma region. Okay? And if you look right here in multiple myeloma, you have that one big peak in your gamma region. So a monoclonal results from a single clone of lymphoid plasma cells producing elevated levels of a single type of immunoglobulin. Okay, so it's a single type. These tend to be more malignant. Okay, so first couple, we'll talk about 2 of them here. The first one is multiple myeloma. And my husband's grandmother actually died of this. Actually, it was complications from it. It wasn't specifically multiple myeloma that killed her, but I remember when she got it, she was diagnosed with it. I was a student at Stevens Point, and I was so excited because I had been learning about it. So I even did a paper on it. So multiple myeloma happens when plasma cells, we know plasma cells are B cells that secrete antibodies, right? Well, they get out of control. They get a mind of their own, and they start secreting one of immunoglobulin. We don't know why, but it causes a dysproteinemia. It sludges up your blood. Okay, you have way too much of this immunoglobulin floating around. If you have beta-2 microglobulin present in the beginning, it's a poor prognosis, usually years. I want to say grandma lived about 3 years. You have weakness, anemia, bone pain. You can have hepatic and splenomegaly. We find interleukin-6 as a major growth factor with this disease. We'll find rouleau on the smear because of all the excess proteins kind of strips that zeta potential so the cells start to stick together. We find Bence-Jones protein in the urine. That is a big kicker. I don't know if that comes up on a lot of people's boards, I would think. So having Bence-Jones protein, you to believe that they have multiple myeloma. It's easily filtered through the glomerulus due to its small size. And again, we see that tall in the M protein region, which is what you see on that top where I circled it in black here. Okay. All right, so what about the next one? Waldenstrom's macroglobulinemia. With this one, you have large amounts of immunoglobulin. It doesn't happen as often. Usually a 3-year survival. It's similar to the symptoms of multiple myeloma, but you have Raynaud's phenomenon. Raynaud's phenomenon is you can't stand cold, and I worked with someone that had this. Her hands, like if it was, we turned the air conditioning way up so it was nice and cold in the lab, her hands couldn't handle it. She had to keep her hands in, like touching her stomach because her hands would get so cold that she couldn't really move them. So in the winter, your hands turn white and they're freezing. That's Raynaud's phenomenon. Controlled proliferation of the B lymphocytes again. Heavy accumulation of IgM in the plasma and bone marrow. And you can have lymphocytosis, so you have excess lymph. You find rouleau, increased fed rate, and you can have a monoclonal spike on your electrophoresis as well. Okay, so the determination to find out which one it would be. All right, so you can also have a light chain disease. This is where only light chains or Bence-Jones proteins are produced. And lastly, polyclonal gammopathy. That's usually secondary to a disease and is characterized by elevation of 2 or more immunoglobulins. Usually we'll see a double peak or a strange, let me see if I get my circle here, or some type of a strange elevation in the gamma region. Notice what normal looks like above it and what polyclonal looks like. It's like a large, it's not one giant like spike of a peak, it's kind of just a bigger hump there. Usually it's not malignant. Lots of things can cause polyclonal. You can have renal inflammation. Hepatitis can cause a polyclonal gammopathy. So there's many different things. Nephrotic syndrome. Lots of different things that can cause polyclonal gammopathies. Usually not malignant. They're usually more benign. And the monoclonal gammopathies are the ones that are usually more malignant. All right. Moving on to rheumatoid arthritis. This reminds me of my grandmother. She was just like this, maybe not quite as bad, but she, as she got into her 90s, she couldn't knit anymore. She even switched over to crocheting because that's easier to do than knitting, and eventually her hands got so bad that she just couldn't do it anymore. But the etiology of this is unknown. It strikes more males than females, actually, usually beginning at age 50. It does shorten your lifespan, and the frequent cause of death is actually cardiovascular disease, not from having it in the joint. It's a multi-system autoimmune disorder, inflammatory disorder of the joints, and there's usually 3 stages to this. You can have the initiation of the synovitis, which is in your fingers and in your joints and things like that. And you can have more events that perpetuate the initial inflammatory reaction. And this inflammatory reaction is the synovial fluid to a proliferative destructive process of tissue. So it starts to spread out even further and further. The signs and symptoms aren't just having aching and stiffness in the morning, but also having fatigue, anorexia, and weakness. So it's just a whole body as a whole, rather than just having a general arthritis because you're getting old. A couple mechanisms they think might cause it. The first one is extravascular immune complexes. They think that there might be immune complexes that get in the joints and cause these issues. The other one could be cell mediated, that cells are going in and destroying the joints. How do we find this? Well, first they have an elevated send rate. We'll find that on the electrophoresis, there'll be an elevation in the alpha and gamma fractionation. Rheumatoid factor, which is an antibody specific to the antigen determinants, either IgM, IgG, and IgA. We did that when you were in lab on rsmith1. Immune complexes would be present. Complement levels are usually normal, unless it's so severe. And the ENA is positive in almost up to 20% of those patients. A couple other types of arthritis can be Felty syndrome. That's rheumatoid arthritis with splenomegaly and leukopenia. That one will find a high rheumatoid factor. We'll have a positive ENA, and you'll have nodules present. We also find low complement. So that is like a severe rheumatoid arthritis. Next one is juvenile rheumatoid arthritis. Very unfortunate. These all they want to do is run outside and play, and Mother Nature decides to give them a nice case of rheumatoid arthritis. So this can be caused from an infection. It can be autoimmune, usually before 16 years of age. And there's a couple different subgroups of this: Still's disease, polyarticular onset, and then actual rheumatoid arthritis. So it's kind of a bummer too. All right, let's talk about organ transplantation here for a minute. Why do we care about that in immunology? Well, it's very important that when you receive a kidney or a liver or anything else, that it's a good match for your body. As you've learned in all of immunology, is if there's something foreign that enters your body, whether it be a bacteria or a kidney, it doesn't matter. Your body's going to recognize it as foreign and try to kill it. So if we get the best MHC match for the HLAs, then our T cells are not going to notice that as foreign quite as quickly. While it's very difficult to get a perfect match full of a allograft or an autograft or a syngraft. Syngraft would be the best way to go, and we'll talk about those in a minute. From an identical twin to the other identical twin, that would be a perfect situation. But in most cases, you just have to get as close as you can. So that's what they do, HLA typing, to make sure it's as close a match as you can get. And we'll throw this in here too. HLA-B27 is a HLA antigen that's linked to ankylosing spondylitis type of arthritis. But anywho, put that aside. Transplantation terminology. We can have an autograft which is from the same person to the same person, such as skin. I think of burn patients. If you get sent to the burn center and they your arm is burnt all the way down to the muscle, they might take some skin off your tuchus so it starts to grow back as new skin. The other thing is a skin graft. That's between the monozygotic twins. That would be ideal. We can have an allograft or a homograft, which is human to human. So that would be like from me to Lori Berkeley. And xenograft, a pig heart to a human. So it's like an animal to a human. So what do they do to prevent all of this autoimmune reaction from happening? Well, they give them medications. And, of course, no match is going to be a perfect match. So I'd say 100% of all patients who get a kidney transplant are going to be on anti-rejection. The first one they usually start them on is a cyclosporin. That's an immunosuppressive drug. They can also give them corticosteroids, which inhibit antigen-driven T cell proliferation. And if cyclosporin is not working so well, they can give them tacrolimus. That is also K506, and that is 100 times more powerful than cyclosporin. So figure they'll start you off with something weaker, and if they're starting to show signs of rejection, then they will start to increase you up to a tacrolimus. Another type of drug that's similar to tacrolimus. Another thing that can happen is graft versus host disease, and this happens more, it can happen with organs too, but also blood transplant. This is what happens when you give an organ or a blood transfusion to somebody who is immune. Well, if you're immunocompromised and you get a unit of blood or a organ from somebody else, there's still T cells and B cells and things left inside of those tissues or those blood transfusions. And they can wreak havoc or attack the immunocompromised person, which is very undesirable, right? So a lot of times what they do is, especially with blood products, is they irradiate them. They put them in an irradiating machine, and it destroys the white cells to inactivate them so that they cannot wreak havoc in the recipient. That would prevent graft versus host disease. A couple different types of graft rejection. You can have a hyperacute, which is like right away, instantly. That would be like giving a B blood type wise. You can have accelerated, which happens pretty quick. Acute happens fairly quickly as well, and chronic is very slowly over time. We do have some biomarkers we do for rejection. There's a messenger RNA test they can do to check to see if it's rejecting, or a FOXP3M messenger RNA test that tests for renal rejection as well. So how about bone marrow transplantation? Well, the goal of transplantation is to replace someone's bone marrow stem cells with new stem cells. So if you have a cancerous type of leukemia and your bone marrow keeps producing more and more malignant cells, what they need to do is destroy all of those cells within your body as best they can with chemotherapy. And then they take the bone marrow from a donor and they actually inject it in the veins of the recipient. What happens, and this is amazing to me, I don't understand how cells are this stinking smart, but those stem cells that are given from the donor to the recipient magically make their way from the bloodstream into the bone marrow and start to proliferate new, fresh, healthy cells that are cancer-free. To me, it's absolutely amazing. I don't even know how Mother Nature makes this work. That's how that works. Some of the cancers that we treat with this include leukemia, non-Hodgkin's and Hodgkin's-type lymphomas as well. And we just talked about those progenitor cells or those stem cells that have the ability to evolve into different cells. So if you can kill off someone's stem cells that are cancerous and let them proliferate, well, here they got a whole new set of stem cells. Usually they're looking at the CD34 going back to hematology, that those stem cells are CD34 positive. A couple different types of transplants. There can be an allogeneic type of transplant. This is receiving peripheral blood stem cells from a related or unrelated HLA match. Syngeneic, of course, would be the way to go, the transplant from an identical twin. Or you can have autologous. That is where you donate your own cells as cord blood, saving your cord blood. I know when I had my kids, more so my first one, not my last two, I don't think they asked me. I had the opportunity to freeze my child's cord blood. The reason for that would be If your child came down with leukemia, they could get themselves back and they could make new stem cells. The treatment for this is, of course, is chemo and radiation. All right, last section here, tumors. Tumor immunology. Well, we don't deal with the tumors themselves a whole lot in laboratory, but we do deal with tumor markers. And I want to share a story because I love it. It is just so disgusting. And I apologize if any of you have had this type of tumor. But have you ever heard of a teratoma? And I came across this picture when I was making this slide, so I just had to share it. I worked at, I did my first 6 years at St. Vincent Hospital in Green Bay. And I became a PM night shift supervisor at Bellin Hospital in Green Bay. And both hospitals, it was super cool, had the biggest histology department ever. Well, they would come get me when they would find weird things. So one day, Kathy comes running over from histology. She says, Becky, get over here. Of course, I go run. It's like my favorite place to go. She's like, here, we got this teratoma. I'm like, what is a teratoma? She's like, it's a tumor with teeth and hair in it. I'm like, are you kidding? I'm like, where do you find a teratoma? She's like, oh, we took it out of this woman's abdomen by her ovary. I'm like, holy cow. Sure enough, you cut it open. It's got human teeth and hair in it. Totally not malignant, but it can cause problems, obviously. You don't want to have a giant lump growing teeth and hair inside of you because it can cause some pain, I would imagine. But she would always come get me when she'd find these things. I thought that was really interesting, so I had to share that. So if you ever know someone has one, that's potentially what it could look like. And this thing had teeth and hair in it when they cut it open. So anywho, usually the study of oncology is involved in the study of tumors and things like that, and cancerous tumors. A couple different types. It can be benign or malignant. It means that it can't spread and metastasize to other areas. And malignant means that it can spread and metastasize to other areas of the body. Some of the stages, we have initiation, promotion, progression of cancer. Review what is apoptosis, that cell death that just naturally occurs. Think of a red cell, lives 120 days. It's only going to live 120 days. That's the only choice it has. Proto-oncogenes and oncogenes are things that cause our cells to proliferate and sometimes proliferate abnormally when we refer to the oncogenes. Viral oncogenes can be Epstein-Barr virus and human papillomavirus. We saw earlier that Epstein-Barr virus can cause Burkitt's lymphoma, and human papillomavirus can cause cervical. Skipping past oncogenes in P53, body's defense against cancer. Well, T lymphocytes can help us fight off cancer. Natural killer cells can destroy cancer cells sometimes. Macrophages and antibodies. We treat tumors by immunosuppression, vaccination, and gene therapy. While vaccination is not used very readily right now, I've been reading a lot more and more articles about how they're making different vaccines for different types of cancers. So imagine being able to make an antibody to a certain type of breast cancer. You inject that person with that antibody. Those antibodies go to those cancer cells, and your body kills those cancer cells. How cool is that? I'm hoping that's the way of the future. That would be really neat if we could vaccinate all our daughters with cancer and things like that. Lung cancer would be another big one, GI cancer. If they could figure out what makes those certain cells or what makes them so special, and they could make an antibody to it, that would be a fantastic way to get rid of cancer. But like I said, I'm not a research scientist, so what do I know? But it would be really neat to see. All right, let's go to our last and final case study here, and I will review the answers to this at the beginning of our live question and answer session. So go ahead and take some time to get a lunch or whatever. I don't know what that, but go ahead and review this, and we will begin our live Q&A session at about 2 o'clock. See you guys later.